Welcome to What's the Proof, the family medicine podcast that seeks to help family physicians and other clinicians incorporate the best available evidence into their everyday clinical decision making. My name is Bobby Scott. I'm one of the faculty members at Caviness Family Medicine Residency and assistant professor, soon to be associate at Wake Forest University School of Medicine. With me today is Sandy Robertson and Don Caviness. Sandy, how are you doing?
I'm doing great. How are you, Bobby?
I'm excellent. Don, how are you?
I'm doing well. Excited to be here.
Yeah, me too. This is episode 10. We are in double digits now.
I know. Does it feel like it's been more though, Bobby?
Yeah.
I bet for you, I bet it does, because Bobby does all the hard lifting for the audience.
Especially after our technical difficulties this morning trying to get this set up. Yeah, it feels sometimes like a lot.
I know.
Bobby, we're such a joy to work with.
True.
Didn't it just fly by? It flew by for me.
It did. It felt like it. Yeah. Mm-hmm.
Just for those listening, whenever there's any type of technological issue, Bobby works to fix it, and me and Sandy just banter back and forth the whole time.
Right.
So we're super
Fun.
helpful.
That's right.
It's lovely. It's a wonderful experience. Well, I did want to share some exciting news with the audience. So this episode and new episodes of What's the Proof can now be found on YouTube. So for those of you who prefer to consume your podcast by video, you can now watch us from the comforts of your couch, perhaps with a tasty snack or a favorite beverage. But you can subscribe to our YouTube channel and be the first to know when our new episodes are published. How do you guys like that idea?
Well, I hate any kind of video, so it's fine. I've had to learn to deal with it, but I don't think it's fair that we don't have our snack and our favorite beverage. And I do realize it's 11 o'clock on a Wednesday and we're at work, but
I guess it depends on what your favorite beverage is.
This could be a lot more fun with my favorite beverage.
Yes, it could. Yep.
By the end of it,
technical difficulties wouldn't be so bad.
That's right.
We got to keep the facial expressions in check.
That's right.
There.
That's right.
Very expressive. So.
Yeah. You can't have the resting kind of face.
Yeah.
Anyway, without further ado, let's get started on today's topic. We've got an episode that is jam-packed today, so I'm super excited.
Okay, so hot flashes. So hot flashes and night sweats are the most common symptom of menopause. I know all of us have had patients come in miserable with these symptoms. And this is what I think is really interesting. Honestly, I did not realize how many women are affected. 80% of women. And it can last, it typically lasting 7 to 9 years if you're lucky. Because 1/3 of women experience this for more than 10 years. So I'm going to say that again because I think it's super important. 80% of women lasting 7 to 9 years, and then 1/3 of women for more than 10 years. So the highest efficacy rates for treatment of vasomotor symptoms are found, we know this, with hormone therapy. And this is considered first-line therapy by the North American Menopausal Society for women younger than 60 within 10 years of menopause onset with no contraindications. And Sandy has done a lot of work around this with our group of physicians trying to help us, get comfortable again, prescribing hormone therapy as it is first-line therapy. Despite this, hormone therapy is underutilized, and there are many reasons for this. And this could be its own episode. Maybe it should be. That's future discussion, but it definitely could be its own topic, and Sandy is expert on this. But today we're going to focus on non-hormonal treatments for women who cannot or choose not to take hormones for vasomotor symptoms. So first, let's review who should not take hormonal therapy for vasomotor symptoms. So contraindications are personal history of estrogen-sensitive cancer, including breast cancer, coronary heart disease, myocardial infarction, stroke, venous thromboembolism, and then, of course, if they have inherited risk of venous thromboembolism, that would be a contraindication. So in 2023, the North American Menopausal Society wrote a position statement on this topic, and they formed an expert panel to review all pertinent literature and to make recommendations. So you remember level 1 is kind of good, consistent evidence. Level 2 is kind of limited, inconsistent evidence. Level 3 is more consensus expert opinion. So Bobby, you want to dig in here and kind of tell us what's the proof?
Yeah, so the NAMS divides these therapies into 5 different categories: lifestyle, mind-body techniques, dietary supplements, acupuncture, and prescription medications. And let's begin with the evidence for lifestyle interventions. So keep in mind that although most of these things are not recommended as effective treatments for vasomotor symptoms of menopause, most of these recommendations are not harmful and may actually have other health benefits. So the first example they give are cooling techniques. So this would be like, changing your clothes, wearing lighter clothes, adjusting the environment in which you live in. And there are only a couple of small trials cited here, and they have conflicting results. So this is therefore not supported by the evidence at this time. And it's common to counsel women going through these symptoms to avoid potential triggers. So alcohol, caffeine, spicy foods, hot liquids, these are common triggers that are thought to provoke the hot flashes. And really, there are no trials looking at this as an intervention. So there's really no evidence to support that as a treatment for this. Now, exercise and yoga, there is more of an evidence base available for this. Evidence from randomized controlled trials indicate that neither exercise nor yoga significantly reduces the frequency or severity of vasomotor symptoms associated with menopause. In studies conducted by the Ms. Flash Network, which I think is a fantastic name, both a 12-week aerobic exercise program and a yoga intervention focusing on specific poses and breathing techniques showed no significant difference in vasomotor symptom outcomes compared to control groups engaging in usual activities. Pooled data from these trials revealed minimal reductions in vasomotor symptom frequency and bother for both interventions, similar to those observed in the control groups, suggesting that there's a strong placebo effect rather than a true therapeutic benefit. Additionally, Cochrane reviews cited in the NAMS position statement corroborate these findings, showing insufficient evidence to support the effectiveness of exercise and yoga in managing vasomotor symptoms. Thus, despite their general health benefits, exercise and yoga are likely not effective treatments for menopausal vasomotor symptoms. Mm-hmm. Next is dietary modifications, and there's very little evidence available from clinical trials on this, and the results from what we have in observational studies is inconsistent. Nutrition studies are inherently difficult to conduct in a way that reduces biases to an acceptable degree. And specifically, when it comes to treating vasomotor symptoms, there really is no compelling evidence to support any dietary interventions. And then finally is weight loss. Now, there are smaller randomized controlled trials suggesting that weight loss may reduce vasomotor symptoms, which is very promising. But larger trials are needed to say this with any significant level of confidence. So the bottom line with these lifestyle interventions, lose weight if you need to. And this might help with your hot flashes, but otherwise, there's really no reason to restrict yourself from certain foods or beverages to manage these symptoms. And additionally, carefully weigh the potential effects on your utility bill and on others in your household before you go about setting your thermostat to 60 degrees.
That is a great summary, Bobby. You mentioned the placebo effect in the trials on exercise. So, and just, let me just tell you, I've experienced a hot flash while doing down facing dog, and it's not fun. Yeah, it's not fun. So, I love yoga, and it does calm me. But in the midst of down facing dog, when you're having a hot flash, that's not a great moment.
Seems like that's going to ruin your flow for sure.
Little bit. But you can rebound, you can get back at it. But let me go back to this placebo effect, okay? Because placebo effect is seen throughout all kinds of studies. This is not a new thing, but particularly with these vasomotor symptom studies is quite impressive. So the placebo effect is consistently shown to have a 20 to 60% improvement rate in trials for vasomotor symptom treatment. And I don't really know what that suggests, but it does appear that a rather robust placebo effect is involved. Additionally, women with higher levels of anxiety over their symptoms, so very, very anxious about their symptoms, have been shown to have a higher placebo response rate, which kind of makes sense. And these are the things worth keeping in mind when evaluating these treatment options. So, Dawn, do you want to start next with the evidence surrounding mind-body techniques?
Absolutely. So mind-body techniques. So this includes quite a few things. So cognitive behavioral therapy, CBT, mindfulness-based interventions, clinical hypnosis, paced respiration, slow breathing techniques, and relaxation techniques. So let's spend a little bit of time on CBT. So the initial studies done on this were 2 randomized controlled trials. Menos 1, I'm going to call it Menos because it's Menos, which means less in Spanish. I'm using Spanish pronunciation, which I think is quite clever. I don't know. I have to research this. I think the researchers may have used Menos, which means less in Spanish, means less hot flashes. That's what I'm thinking, but we'll see.
I love it.
So Menos 1 and Menos 2, the first found benefit from group CBT in breast cancer survivors, while Menos 2 showed a reduction in vasomotor symptoms and problems in perimenopausal and postmenopausal women without breast cancer from both group and self-guided design CBT. So subsequent studies have expanded CBT's application, demonstrating its efficacy across different delivery modes and populations. And this is important. This includes nurse-delivered CBT, online CBT, CBT self-help books, which is really important because this will make it much more accessible, given concerns over availability of CBT therapists and just the cost of formal CBT and just the availability. So overall, the North American Menopausal Society gave this a level 1 rating and declared this a recommended treatment option. And then the other thing I mentioned was clinical hypnosis. And this is new news to me as we were looking over these recommendations. So this is very interesting. I have to say I've never referred to a hypnotist before. So I'm taking this in as I'm sharing it. So, there is some evidence suggesting benefit. So there were 2 randomized controlled trials cited, one which looked at breast cancer survivors and another postmenopausal women in general. Both studies showed a reduction in hot flash frequency and severity compared to a control group to reduce the frequency and severity of vasomotor symptoms. The reductions in the second trial, now this was an N of 187. It was substantial, with hot flash frequency reported 74% in the control group versus 17% in the hypnosis group, as well as reduced hot flash severity, 80% versus 15%. So they gave this a level 1 grade and recommended therapy. So.
Wow. Well, that's very, very intriguing. I do want to give a word of caution about interpreting those results too strongly. One of the challenges of performing a high-quality randomized controlled trial on clinical hypnosis is the difficulty in finding an adequate control. And this is really difficult for any type of procedural intervention because the closest thing you can get to a placebo is a sham procedure. So any other control is going to fall short of that and keep you from being able to double blind. So, ideally, the control you would have for a hypnosis study is going to be a sham hypnosis session. And from what I understand, there are technical challenges in creating an appropriate sham hypnosis. I can imagine that is the case. The first study on this used no treatment as their control group, which is frankly, to me, useless for drawing any meaningful conclusions other than we should study this again with a better control. The second study, though, the one with the strong reduction in symptoms, does make a better attempt at an adequate control by using a control group that received 5 weekly sessions of structured attention control. So they designed those sessions to match the therapeutic environment, the therapist interactions, and the discussion of symptoms that the intervention group got in their 5 sessions, but the intervention group also got hypnotic induction. So that is definitely a better control. But in my opinion, a level 1 evidence rating is a bit strong based on just those 2 studies alone. But anyway, I'm done with my soapbox. Dawn, you can continue.
And in addition to that, I don't know enough about hypnosis. Is there any downsides? Are there any risks? And I need to study all this more. But so thank you, Bobby. Thank you for your input on that. And it's really important to think about that. And it is interesting that it was a level 1 evidence rating. So next on our mindfulness-based interventions is the mindfulness-based interventions. Ultimately, this has not been studied enough to recommend at this time. Studies looking at paced breathing showed no benefit in alleviating the vasomotor symptoms, and this is not recommended. Evidence for benefit from relaxation techniques is limited and inconsistent, therefore not recommended. Although, again, does it do harm? So it's kind of, that's a shared decision making. If they want to do that, certainly women could do that, but we can't promise that it's going to be much benefit. So bottom line, when in doubt, CBT for everything.
It's always the board answer.
It's always the board answer.
Always the board answer. And for vasomotor symptoms, hypnosis also has positive results. So
I feel badly that I have not scheduled my CBT and my hypnosis, and I probably need to do that. It would help me get through my yoga class, right? Do you think? I don't know. Oh, okay. Thank you, Dawn. That is a really good summary. And I will admit to you, just like you admit, I'm clueless on hypnosis. I wouldn't even know where to refer. But even in the field of CBT, I know exactly who to go to. I know whom I would go to. We have access here. We have fantastic psychologists. But as far as self-guided and nurse, self-instructed, I need to do better at that. So I'm going to try to look into that for myself. So I will admit that to you. Okay. Are we ready to go on to dietary supplements? Yes?
Yes. Let's do it.
Okay. It's got to be the diet, right? Okay. Soy. That's the big question. So soy supplements and extracts, and also the soy metabolite equal. So I don't know if you guys have heard about these different terminologies, but there are mixed results for all, is the bottom line. Some of the data suggests that soy is effective, but it needs to be consumed for up to 16 weeks before any expected result. And it's really hard to carry that out and to be consistent, to have the same amount of supplement up for that long. It is interesting to me in just reading for this podcast that only 35% of North American women can actually metabolize soy to the form of equal, which is basically a very low potency estrogen. But only 35% of women can actually metabolize that. So that's a huge confounder, a huge, not really a bias. It's your genetics, but we don't know who those women are going to be. So I found that also very interesting. So small studies do not show an increase in the risk of recurrent breast cancer when you are taking soy supplements or foods or ingested that contain a lot of soy, drinking soy milk. So it's considered safe. And for a while, that was even in question. So we do at least have safety data with it, but the efficacy data is very limited. So the North American Menopausal Society assigns this a level 2, and they say it's not recommended just because of inconsistent results. But I can at least say that I feel that it's fairly safe to do. And then black cohosh is the one that we all talk about. It's probably the one that most women have tried before they come in. Everyone talks about it on social media. A 2012 Cochrane review of over 2,000 peri- and postmenopausal patients, women, did not show improvements in vasomotor symptoms compared to placebo. So as much as I hate to say it, black cohosh does not work, and I can't recommend it. But when I flip it and I look at the safety, I do think that it is safe. And then you put in the placebo effect and you're purchasing something and you believe it's going to help. So it's in that situation where I'm okay with it when women try it. But as far as me trying to sell it, it gets very difficult for me to sell, unless I'm just trying to sell placebo. And I guess I can get in favor of that.
I mean, that's basically what you're doing there, is you're taking a placebo.
You're taking a placebo. And so I would say maybe in that light, find the cheapest placebo you can find.
Yeah, there you go.
I don't know. The bottom line for this, though, is save your money. It's really hard for me to recommend it. But if it's cheap and you want to do it, I think it's fairly safe. So, okay. The fourth category is acupuncture. And again, I'm so intrigued. This is something that I need to know more about. But traditional acupuncture versus no treatment has shown modest benefit. But when compared to sham acupuncture, as Dr. Scott just astutely educated us on sham procedures, the results are the same. So level 2, not recommended. So there was really no difference between the sham and the actual procedure. This highlights the caution that you were mentioning earlier, and you have to be kind of careful with that. So the bottom line with acupuncture is we do have positive data. I'll just put a little plug in for, insomnia and pain in certain situations. But when you're looking straight at hot flashes and vasomotor symptoms, it's not effective. So, and it's about $100 per session. I did find that out. So it's a fairly expensive kind of sham thing. But if you have pain and insomnia and some other reasons, maybe if you change your focus to that, because certainly insomnia can come with with menopause as well. So maybe it could be beneficial in that light. Yeah. Okay. Are we ready to go to kind of, my favorite, which is the prescription medications?
Yeah, we're doctors. We love prescriptions.
We do. I'm actually a pharmacist that tries so hard to get patients off of everything that this is absolutely necessary.
Yeah.
But I'm putting this up there, guys, okay, as a person who actually is taking such medications. It happens to be in the hormone realm, but there's a distinct difference. So I do have a little bit of my own bias here, but we're going to focus on the non-hormonal prescription medications because I'm happy to tell you there is some positive data with it. So some of our strongest data for improvement with vasomotor symptoms is with the SSRIs and SNRIs. These trials are fairly well designed. They are blinded with objective questions and diaries for women to complete. Most of these trials include women with bothersome symptoms and no history of depression or generalized anxiety disorder concurrently. So these are women that you're not just, treating the depression and anxiety and, oh, by the way, it may help the hot flashes. So it's very important to understand that these are non-depressed, non-anxious currently. Their PHQ-9 and their GAD-7 are showing, healthy levels, but they're on SSRIs or SNRIs versus placebo in these trials. So the only FDA-approved antidepressant for vasomotor symptoms is paroxetine, 7.5 milligrams, very small dose. But there are other off-label options, and we do off-label all the time, so you know that. Specifically, there are trials with escitalopram, citalopram, venlafaxine, and desvenlafaxine that have all shown significant reduction in vasomotor symptoms. And these are large, double-blind, randomized control trials. All of these women were symptomatic. Duloxetine has also been shown to reduce symptoms, but the trials were smaller, but that is another option that showed some positive results. So collectively, when you pull all these together, hot flash reduction varied from 25% up to 69%. So, and it is hard to kind of discern exactly which one is going to be the most effective. And I don't want to go and out on a limb and say that one SSRI or one SNRI is superior than another because they haven't been directly compared to each other. And so they are all considered moderately effective. When you look at a pooled analysis of escitalopram between 10 and 20 milligrams versus venlafaxine 75 milligrams versus estradiol, so this was a pooled analysis, but the estradiol dose was only 0.5. So just to make sure, 0.5 is usually the starting dose. 1 milligram is the typical dose. Some women go up to 2 milligrams, so that's in the estradiol family. When they did a kind of head-to-head comparison of that data, they showed a daily reduction in hot flashes of 2.3 more than placebo with estradiol and 1.8 more per day with venlafaxine and 1.4 more with escitalopram. So it all worked in reducing the number of hot flashes, but you can see that it was 2.3 more with estradiol, 1.8 with venlafaxine, 1.4 with escitalopram. So these women had to have at least 14 bothersome hot flashes per week to be enrolled. Okay, now that is not insignificant, but you're going to see in later trials that 14 per week is not the same as like 10 per day.
Yeah.
Okay. So 14 per week. And I applaud them for including that because it's hard to categorize whether you're having, moderate or severity of your vasomotor symptoms. It's so subjective.
Yeah.
But I will say this of note, when the estradiol 1 milligram dose is studied, it is definitely proven to be more effective in this population with an average of a 75% reduction in bothersome hot flashes. So just know that, when you compare estradiol, it was the smaller doses, and the higher doses, we all know that hormone therapy is superior. But overall, the SSRIs and SNRIs were given a level 1 recommendation by the North American Menopausal Society. So I don't know if you noticed in my spitting off all of these medications that I did not include fluoxetine and sertraline. And that's not insignificant. I just want to kind of bring that up. These two have also been studied, and they did trend towards significance, but it didn't meet statistical significance. Also, you need to think about the side effects and drug interactions with all the SSRIs and SNRIs. So you need to specifically look at drug interactions. And the one that I just want to make very clear is that with paroxetine, which is FDA approved, shown to be effective, and fluoxetine, not FDA approved, trending towards significance. Both of those are your, strong cytochrome P450 2D6 inhibitors, right? When you have a breast cancer survivor that is now on tamoxifen, that person needs that 2D6 enzyme to metabolize tamoxifen to its active form. It does not work if you don't have the 2D6 in check. So studies have shown a recurrence of breast cancer in women who take tamoxifen and also take either fluoxetine or paroxetine. So for that reason, you would not want to use those medications. So if you are on tamoxifen, you should not take paroxetine or fluoxetine. So just make sure you're just checking in on those drug interactions. Little things like bleeding and hyponatremia, SIADH. These are all the things that come with SSRIs. I know we like to think about them being completely safe, and they are safe and effective medications, but we forget about sometimes these serious, rare side effects that can come with medications. And I think patients have a right to know kind of what you're going to be monitoring for and looking for. Okay, so SSRIs, SNRIs, check. Gabapentin, tell you it's all the rage. When in doubt, CBT followed by gabapentin, right? It just seems like it works for everything. But it comes with a cost anyway. That's my own bias. It was hard for me to, I can't tolerate gabapentin very well. I get very sedated with it. But gabapentin titrated to 2,400 milligrams a day, which is a pretty hefty dose, has been shown in small trials. So these are about 60 women to reduce hot flash frequency by 71% compared to 72% with a conjugated equine estrogen, 0.625 milligrams. The placebo rate in this trial was 54% though. So it's really interesting. Wow. So placebo was 54% reduction, and 72% with your doses of conjugated equine estrogen at 0.625, and then 71% with 2,400 milligrams of gabapentin. So I don't know. That's kind of hard to look at the difference of that, see how clinically significant that is. And you guys know this better than I do. Headache, dizziness, disorientation, very common with those doses of gabapentin. The number needed to harm has actually been shown in the trials to only be 4. So you only have to treat 4 women to cause one of these side effects. So the North American Menopausal Society gave gabapentin a level 1 recommendation. But my biggest concern is just the frequency of the adverse effects. You just have to really follow it closely and make sure the patient understands. And some people can tolerate it very well. And for that reason, you can keep it going. But if they're not tolerating it, I would probably, I would be quick to disarm that. So pregabalin, sorry, I can't say the brand name. Pregabalin has, sorry, that was like a pharmacy slip, wasn't it? That's I'm sorry. I mean, I like to be bilingual, but, people get angry with me for that. It has shown similar results in very small trials, but given the high rate of adverse effects and just the simple fact that it's a controlled substance, I don't know that anybody's jumping on to go that route with vasomotor symptoms. Okay. Then we have a new class. Okay, are we ready to go to school? Yeah. Are we ready to go back to medical school? I'm going to do my best, okay? There is a new class of medication that is FDA approved for the treatment of vasomotor symptoms called the neurokinin B antagonist. And fezolinetant, and I am going to say the brand name because you need to know it because people are going to come asking for Veoza. Yeah. So it's on TV. It is on TV every day. It's on my Instagram. The fact that it's hearing me right now, I'll have advertisements all afternoon about it, okay? It's the first FDA approved agent in this class. And this really gets to the core of what causes a hot flash, which I find so interesting. And I don't truly understand it, but I'm going to try to describe it, okay? So there is a thermoregulatory center in our hypothalamus that becomes disrupted when estradiol levels declines at menopause. Can I get a witness? It is true. It happens, okay? You can't will it away, okay? The specific hormone that regulates the center is gonadotropin-releasing hormone, which is regulated by 3 smaller hormones that we like to call the pacemakers, okay? It's kisspeptin, neurokinin B, and dynorphin. Now, when they refer to this in in the studies that I was reading and the review articles, they refer to these 3 smaller hormones or pacemakers as the candy pacemakers, starting with a K.
Great. Yeah,
Isn't that great?
Great. Yeah.
It's a candy problem, right?
Yeah.
So specifically, if you look at neurokinin B, that serves as the stimulator in your thermoregulatory center, and dynorphin is the inhibitor of this regulatory center, and it's very disrupted by your estradiol levels going down. So by antagonizing your neurokinin B, there is less hypersecretion to the thermoregulatory center of the brain, and hence less hot flashes. Yeah.
Okay.
Easy?
Yeah.
Let me see if I have my mind wrapped around this. Okay.
All right.
So hopefully, sometimes we have non-clinicians that listen in.
Sure.
And those of us clinicians that need a little bit more processing, it's also for them too. So if I have this straight, the hypothalamus is part of your brain that acts like the thermostat for your body temperature.
Correct.
And there's the chemicals, the fancy ones you just named, in our body that act like switches that control this thermostat. Neurokinin B turns the thermostat up, while the dynorphin, right? Dynorphin,
correct. Yep.
turns it down.
Yes.
And so when the estrogen levels fall in menopause, neurokinin B basically goes into overdrive, sporadically turning your thermostat way up, causing hot flashes. So this medication works by blocking the effects of neurokinin B, preventing it from doing this overstimulation of the thermostat, and thus hopefully reducing the hot flashes.
Yes.
Okay.
Oh, you're such a good student.
We're back in medical school.
Well, I mean, again, I could go on my soapbox, Bobby, but just to talk about how to describe a hot flash. This is not sweating. This is not me working out. I know exactly what that feels like. This is in your inner core. And when women try to describe it, it's just really hard. But when I think about this internal thermostat and being inside and the disruption of it, that makes me feel a little bit better that people are understanding what I'm trying to describe as the feeling, because it's really, really hard. So very good job of trying to explain that. So I'm always intrigued when we have a new class of medication. Of course, I'm always very skeptical. You have to really prove to me that something works, and you have to prove to me that it's safe before I'm ever going to recommend it. And let me tell you, I have a large inner circle right now of women in their 50s that are all coming to me so it's personal for me. I really want to make the right call. So what is the evidence? Like, does this actually work? I'm glad that we are talking about the thermostat in our brain, but does it actually work? So there is primary evidence that is really coming from industry sponsored, but these are phase 3 trials. So these are the trials that are required by the FDA in order to get FDA approval. They were called Skylight 1 and Skylight 2, and both of these trials are very similar. They enrolled approximately 500 women with moderate to severe vasomotor symptoms. And so this is where it kind of is different from the SSRI trials. They averaged at least 7 episodes per day. So that was, they were having to have a significant amount per day. And they were randomized into 3 groups. There were 2 different doses of the
Fezolinetant.
Fezolinetant. So 2 different doses, the 30 milligrams and the 45 milligrams, and then placebo, of course. The primary outcomes were changes in baseline at 4 weeks and at 12 weeks in the frequency and the severity of your vasomotor symptoms. And at baseline, the mean frequency, just so you know, for these studies, the mean frequency was 10 to 11 episodes per day. So they had to have at least 7 to be enrolled in the trial, but these women were having 10 to 11 per day, not 14 per week like this in the other studies.
Sounds terrible.
It is pretty awful. Yeah, I'd like to see how long you would try to suffer through it, right?
Yeah, no, thank you.
I lasted a whopping 3 weeks before I called in reinforcements from my primary care team. Okay, so back to the studies. In Skylight 1, the mean daily frequency of vasomotor symptoms with the 45 milligram daily dose, which is the dose that was ultimately approved by the FDA, was reduced by about 2.55 episodes per day at 12 weeks compared to placebo. So 2.5 less episodes per day. In Skylight 2, it showed similar reduction in your average vasomotor symptoms at 12 weeks. So a 7.5 episodes per day was the average. So compared, while placebo reduction was basically 5 episodes per day. So So wait, I don't think I made that very clear. Let me repeat that. In Skylight
Okay.
2, in Skylight 2, there was a similar reduction, but at 12 weeks, it went down by 7.5 episodes per day versus
Yes.
placebo, which was 5 episodes per day. So placebo
Yeah.
was not better. Okay. Placebo was
No,
still worse, but
it was a decrease of 5. Yeah.
right. A decrease of 5. Yes. Sorry. I kind of butchered that.
That's okay.
So in both of these studies, the mean reduction is about 2.5 episodes per day compared to placebo. Okay, when you compare it. But remember, the baseline numbers was pretty high, 11. So you'll get 5 less due to placebo, an additional 2.5 whenever you're on the fezolinetant. Okay. So when it comes to the reduction in the daily severity of the symptoms, so the ones that are considered the most severe, the mean difference was small at about 0.29 points, which is not likely to be clinically important. So the severity of it didn't change significantly. But note the difference in the vasomotor symptoms in this trial with the SSRIs, which I already kind of talked about. I mean, it is encouraging that there is data that started to trickle out with improved quality of life, nocturnal awakenings, and sleep quality. And I mean, I can attest to this with myself and with my inner circle. We can handle some hot flashes during the day, and we can even laugh about it. We can joke about it. We can have a better attitude about it. But when you start interfering with my sleep and I'm waking up and when you wake up with these night sweats, it's not just a little hot. It's not like you just have to take the blanket off. You have to literally get out of the bed and decide, are you going to take a shower? You're going to definitely change your clothes. Your sheets are completely soaked. I sleep in the same bed with my spouse. He's fast asleep. What am I going to do? So then I put a towel down. I mean, it's a whole thing. And then you finally get settled back down, and 45 minutes later, it happens again. And that only had to happen to me literally for 3 weeks until I had to tap out and say, I cannot continue to not get sleep. I was probably sleeping, 2 to 3 hours a night. And I can't even pretend to do this job with 2 or 3 hours over time. So that's what really called it for me. So bottom line is, hold on, let me go back to side effects. So let me talk about safety. Very, very safe. Headache was the most common side effect that was reported in the trials. And I believe that was about 2% of patients. And they did see it, the phase 2 trials, some elevations in LFTs. And I'm not super concerned about it, but I like to be very, very conservative, and I agree with what they recommended. So baseline LFTs, 3, 6, and 9 months. And I'm hopeful that throughout time, just like with statins and all the other medications that we learned over years, that we don't have to check LFTs as frequently. I hope that's going to follow suit, but for now, we need to be very cautious with that. So you need to talk about headache as the main side effect, which I know is difficult to, ascertain the cause of your headache. And then you have to check it, liver enzymes for sure. So bottom line for pharmacologic management, prescription medications for vasomotor symptoms, venlafaxine, paroxetine, escitalopram, duloxetine, and fezolinetant all have a shot at helping your hot flashes. Okay. If it's appropriate, consider these. Paroxetine should not be used in women with tamoxifen. So just another little plug for that. And so last thing I'll say, because I do have one friend that's actually doing this, is that we do not have any studies to date on combining any of those SSRIs or SNRIs that I just mentioned with a neurokinin antagonist. But it's reasonable that if you are not getting adequate control with, one of those therapies, say it's venlafaxine, and, you want to try a neurokinin antagonist, I can't think of a pharmacologic reason why that would be a contraindication, because it's just hitting different receptors. It's working 2 different ways. We oftentimes use combination therapies for treatment. So, but it certainly has not been studied yet. I hope that it will be.
Yeah, it seems like that would make sense. So, well, so to wrap things up, it sounds like we have several non-hormonal pharmacologic options available. So when trying to choose one, here's how I guess I would think about it and go and approach this. So the big issue at this point is cost.
Yes.
So it's about $600 a month out of pocket for fezolinetant. Obviously insurance coverage is going to be variable, but it's a new medication. There is a pharmaceutical savings coupon for this. It's similar to the others. You get your first month free. Your following months can be as little as $30 up to an annual total discount of $4,000. And additionally, like most coupons, these are only for patients with commercial prescription coverage. And so although we don't have any head-to-head trials, fezolinetant seems comparably effective to SSRIs and SNRIs based on the evidence we have thus far. And it seems like it may have a better safety and tolerability profile. So I think eventually we may see fezolinetant as the first-line non-hormonal option. But practically, because of this cost barrier, even though I would likely recommend this over an SSRI or SNRI, most patients are probably not going to be able to afford it right now.
Yeah, Bobby, I tend to agree. If cost weren't a consideration, I might lean towards this as a first-line option for women who can't or won't take hormones for their vasomotor symptoms that are negatively affected by, their quality of life is bad, and I tend to agree. But they do not currently suffer from depression, anxiety, then certainly I would go that way. If that is a confounding factor, then I certainly would lean towards the SSRIs or SNRIs. So you just have to, share decision making and for your first choice. So I think that's why it's. And I guess, Dawn, do you agree with that assessment? So depression, anxiety, some other issues going on, maybe we'll go the SSRI, SNRI, but otherwise, if they can afford it, be something that you'd be willing to try as long as the liver enzymes are not an issue, right?
I agree. I think that, and I'm lucky to have Sandy as my in-house personal menopause expert. So we've had numerous cases that we've kind of used this kind of algorithm, this pattern. And I do agree. I think it's a good strategy.
Good. I'm glad that we think alike on this. And I just want to reemphasize the efficacy of CBT. And I'm preaching to the choir right here because that is something that I think CBT is probably good for everybody every single day, right?
Yeah.
But I'm gonna make that commitment to you guys here on the air, right? I'm gonna look into that and see if I can get better at that.
Yeah. Very good. Well, thank you both. That's all for today's episode. We'd like to thank all of you for listening. If you enjoy this podcast and you found it useful to your clinical practice, really the best way you can support us is by sharing it with your colleagues, your friends, and even your patients. And we would also love to hear from you. So we invite you to share your experience, your thoughts, your questions about today's topic with us. And also, if you think there are topics that would be valuable for us to cover, please share those as well. You can reach out to us by email at whatstheproofpodcast@gmail.com or on X, formerly known as Twitter, @theproofpodcast. Until next time, this is What's the Proof?